Good evening, everybody, and welcome to the next in the series of Rural Health Waste webinars. We're pleased that you're able to join us this evening for the Palliative Care in General Practice webinar. Before we start, I would like to acknowledge the traditional owners of the land on which this event is being broadcast, and we would like to thank them for providing access to this part of their country. A little bit of housekeeping also before we get started. We do have everybody muted so as to minimize background noise. So you should be able to hear us loud and clear at the moment, either via your audio on your computer or through your telephone. But whilst we have you unmuted, we would still love to hear from you. We'd love to hear your questions. So you do have access to write questions to us. You should all be able to see your dashboard. You might need to click on the orange arrow to expand your dashboard, but through that you should be able to see your questions and answers box. So please feel free to send questions to the presenter as she's going along with the webinar, and she's happy to respond to some of those questions as she's going through too. So your presenter for this evening is Associate Professor Alison Parr. Alison is the Director of Medical Services at St John of God Murdoch Hospital. She is a consultant in palliative medicine at St John of God Murdoch Hospital and also the Discipline Leader Palliative Medicine at the University of Notre Dame. Alison has a strong interest in education and training. She has chaired research, delivered education programs and conferences, facilitated collaborative education between local adult and children's palliative care services, and has taken an active role in undergraduate and postgraduate medical training and nursing and allied health professional education throughout her career. So without further ado, I'll hand over the reins to Alison. Thank you.
Thank you. Welcome, everybody. Good to be here with you tonight. And I'm going to take you through this presentation. We've got quite a bit of content to get through, but I am happy to respond to questions as we go. And please stop me for clarification as well as we go on if there's anything that you want to ask. I'd just like to say that this workshop was produced by the Queensland University of Technology as an educational resource for health professionals. And I'd like to acknowledge them because this is their content that I'm presenting to you this evening with some of my minor adjustments. Okay, you will receive both pre and post workshop evaluation questionnaires, and we'd like your honesty, please, because that will impact on how we deliver these sessions in the future. So we're grateful for your input there. It is voluntary and it is anonymous, but we would really like your help with that, and we will be feeding back. So in terms of tonight's webinar, we're going to talk through some trends in palliative care delivery. We'll be talking about how we recognise those who need palliative care. We'll touch on communication and advanced care planning, and then we will go into a bit more detail around symptom assessment and management. We've got some case scenarios that we can work through, and we're also going to tell you a little bit about some of the service networks and resources that you can access to help your practice. So by the end of this workshop this evening, we hope that you'll have a better understanding of how to identify individuals in the general practice setting who could benefit from palliative care, that you'll have some strategies for communicating with patients and families about prognosis and goals and preferences for care, that you'll understand the principles of palliative care, including assessment and management of pain and other common symptoms, and you'll have access to resources to support you in providing palliative care. We also hope that you'll have some self-care strategies so that you can effectively manage the issues that rise for you related to working in this field. So we'll start from the beginning with some important trends in palliative care delivery. This is the World Health Organization definition of palliative care, which says that palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So the key parts of that definition are that palliative care is about quality of life, it's about living, not dying. It's associated with the care of people who've got progressive life-threatening illness, and it is about really paying attention to that assessment so that we can manage the problems appropriately, and recognizing the fact that this is more than just dealing with the physical illness, but actually the impact of that illness on the wider social and spiritual and psychological well-being of the people impacted. The key principles of palliative care include relief from pain and suffering, the fact that palliative care affirms life, but also says that dying is normal. Palliative care is not about hastening or postponing death. It is holistic, it integrates those psychological and spiritual components of care, and it extends into bereavement. It works best with a team approach rather than an individual approach, and it's applicable early in the course of illness in conjunction with life-prolonging therapies. And that's increasingly recognised in recent years. We'll talk a little bit more about that later. So in terms of palliative care and how we deliver palliative care, what you see in front of you now is the GSF Prognostic Indicator Guidance, disease trajectories. So the GSF Prognostic Indicator Guidance is something that was developed in the UK by a GP on behalf of the Gold Standards Framework program over there. But there's some recognition that various different types of illness actually follow different disease trajectories. So what we see in terms of our palliative care practice varies according to those various different disease trajectories. So typically, certainly in terms of specialist palliative care, it was first recognised in the care of patients with incurable cancer. And what you can see in that top graph on the right-hand side of your screen there is that for most people with cancer, they follow a course that's fairly stable for much of their illness. But there comes a time where with disease progression, their condition begins to decline, and it declines more rapidly towards death. And it's often at that last point that palliative care, the need for palliative care is recognised, and where services become increasingly involved with the patient. But what you can see on the next graph down is that for people with organ failure, for example, heart failure, respiratory failure, renal failure, you're more likely to see episodes of deterioration with a general downward trajectory. And there are periods of very acute illness that may be very actively treated, but each time a person has that acute illness, they don't quite regain their previous baseline. And it can become very difficult to predict exactly which of those acute illnesses may result in deterioration and ultimately death. But what you do see as the disease progresses is that those episodes of acute care become more frequent. Thirdly, you can see the graph in green there representing frailty and dementia with a very gradual downward decline with some ups and downs along the way. But what we see is that in all of these scenarios, that palliative care has a role, and it should be based on need, not on prognosis or age. So actually, when we're thinking about assessing palliative care need, we need to understand the sorts of things that should be flags to us, and we'll talk about that a little bit more. But we certainly should be thinking about palliative care and the palliative care approach for patients with non-malignant as well as malignant disease. There's growing evidence of the benefit of early integration of palliative care, and we can see that there are a small number of studies here that report the benefits of early palliative care in terms of quality of life and symptom intensity. So having that proactive approach and focusing in a holistic and multidisciplinary way on the care of patients can have quite a substantial clinical significance for patients in terms of their quality of life, if not their function. We also know that there is a role for both general palliative care and specialist palliative care, and that really specialists only see the tip of the iceberg, the most complex problems. Most palliative care is done within a general setting. The third thing to point out here is actually that there is one paper that shows that in lung cancer particularly, early palliative care can have a positive impact on prognosis, that patients can actually survive longer with early palliative care intervention, and that's perhaps something that isn't generally acknowledged. So as I said, specialist palliative care is often involved with just the tip of the iceberg here. You can see that for the majority of patients who have palliative care needs, those needs will be dealt with within primary care. That there's an intermediate level of care, perhaps with more intensive involvement or a wider range of people having some input. But those with the most complex needs have the most intensive input and probably require specialist palliative care intervention too. And what we find with patients is that during the course of their illness, they will actually move up and down between those three levels. Some will never require specialist palliative care intervention. Their problems may be fairly straightforward and relatively easy to deal with in primary care, but many will need that additional level of support at some point. So in terms of core skills for GPs, what are the important things that you really need to be able to do in order to care for these patients in the best possible way? The most important thing is to be able to recognise somebody who's approaching the end of life. And although that may sound fairly straightforward, it's actually quite hard. And the evidence in the literature says that doctors in general are actually quite poor at prognostication and identifying these people who are approaching the end of life. So we'll talk about that a little bit more as we go through. Also being able to consider and record the patient's wishes, the importance of communication here with patients and their families and people who are important to them, so that we can commence advanced care planning, thinking about what we'll do if further down the line, so that actually when we hit a crisis or a change in a patient's condition, we already know what the patient would want in terms of how we should act. We also need to plan for those crises that happen, particularly towards the end of life, whether those are problems with symptoms, whether they're practical, emotional, or spiritual crises, and actually knowing how to access additional resources so that we can work together collaboratively to support patients. So let's think more about that first scenario there, recognising dying. So further with the gold standards framework, as we talked about a little bit earlier, within that guidance is a prognostic indicator tool, and they suggest 3 triggers that can help you to determine whether or not patients are nearing the end of life. The first of those is very general. It's what they call the surprise question. Would you be surprised if this patient were to die in the next few months or few days? You can also flip that around. Would you be surprised if this patient was still alive in the next few months or the next few weeks or the next few days? And sometimes that can give you a general hunch. But the gold standards framework goes on to develop this a little bit further and says that the next step in determining somebody's prognosis should be to look at general indicators of decline, the pace of deterioration, whether or not somebody's functional status is changing and they've got increasing needs, or actually whether they've opted for no further active care. All of those things can be indicators. And then the third thing to look at is the specific clinical indicators relating to particular disease conditions. SPICT is a tool, the Supportive and Palliative Care Indicators tool, that has been developed from this gold standards framework work into a single page document that is becoming increasingly used, particularly within Western Australia, as a tool to help us determine somebody's prognosis. So this is what the tool looks like. And you can see at the top there, it outlines the general indicators of deteriorating health, and below, for specific disease groups, there are particular things that we can think about that might help us to identify whether or not somebody's prognosis is fairly short. And we're looking here at whether somebody might be in the last year or months of life. And the key thing here is when we identify these patients is certainly to take a step back and think about reviewing what we're doing and having those conversations about planning ahead. So the next thing to think about is communicating about end-of-life issues. What do patients want from health professionals? Well, the evidence says that the majority of patients want us to have clear and honest communication. Most people want to know what's happening now, what might happen in the future, what care is available for them, and how they might be looked after, and how they want to talk about how they want to spend their remaining time and what's important to them. This framework, the Prepared framework, was published back in 2007, but I think it serves as a very useful tool to think about how we tackle some of these conversations. So let's just talk through this mnemonic, Prepared. The P is for prepare. Prepare for the discussion wherever possible. Make sure you understand what's happening with the person's illness, and if possible, you've spoken to an expert to understand what their thoughts about prognosis or treatment options might be. R is relate to the person. Acknowledge the fact that actually what they're going through may be quite tough. E is for elicit the patient and caregiver preferences. Some people like to know everything about their illness and what might happen. Other people prefer just to take one day at a time. We know that the majority of people like clear information, but actually it's important for us to find out for that individual patient how much detail they'd like in a conversation. I tend to say, are you the sort of person that likes to know everything about your illness and what might happen in the future? Or are you the sort of person that prefers to be guided by the doctor and just wants to take one day at a time? P is for providing information that's tailored to the individual needs of the patient and their family, offering to discuss what to expect in a sensitive manner and giving the patient the option not to discuss it at all, as we've said. And the key thing here is to give information in small chunks. It helps if you know the person and whether they're somebody who kind of likes you to be upfront and give information quickly, or whether they're somebody that needs a little bit of time at each step to adjust to the information that they've been given. It may take more than one conversation to provide the information to some people. You need to be clear. You need to be talking in simple language that the patient will understand. And you need to be actively listening and reflecting on the patient's reactions as you're going through the conversation. It can be helpful as well to summarise for the patient. Acknowledge their emotions and concerns. So as you're recognising their responses, you can actually acknowledge an emotion that you can see, and you can check out what impact the information that you're giving is having on the patient and their family, and check what new worries that may have provoked or what their biggest concern is at the time. The R is for realistic hope. It's about not giving false hope. You don't want to reassure people that everything's going to be okay when it's clearly not. But you can certainly reassure people that there will be support alongside them every step of the way, and you can make sure that they know how to access that support. E is for encouraging further questions and discussion. The patient often doesn't take in everything that's been said in one go, and it's actually about giving somebody the opportunity to clarify something, to go back over things again, or to arrange another time for a further discussion to talk about the next steps. And then finally, the D is to make sure you've documented that discussion and perhaps the person's reaction and questions, and a final plan. So if we then think about advanced care planning, this is a process where people can discuss their own personal values and their preferences for their healthcare for the future. And that can involve family, friends, and a healthcare team. At some point in the future, if the person is not able to make their own decisions or can't communicate those decisions, then the advanced care plan can be used as a guide to help us make appropriate treatment decisions that are in keeping with the person's wishes. That plan can be written down to ensure that preferences are respected. In Western Australia, we can write an advanced care plan, or we can have an advanced health directive. Ideally, the advanced care plan should be written down, but actually it can just be a conversation. As long as we know what the person's wishes are, then actually we can document that in our medical notes, and we can share that information with other health professionals as well, even if the person doesn't have their own copy. People don't have to be ill to make a plan. I have an advanced care plan, an advanced health directive, and actually it's much better to make these plans when you're well enough to be able to take on board information and think things through. I think we do have to acknowledge, though, that people's preferences can change over time, and we do need to check back and just make sure that what we've documented previously is still in keeping with the person's wishes. Having that conversation can be quite challenging, and often people don't quite know how to approach it. But what I will often say to somebody is, tell me what's important to you. Let's think about the things that add quality to your life. What are the things that you value most? And then we can begin to tease out at what point would life have less value, and how would that change how they would want their care to be delivered. People can also choose someone to make decisions for them. So some people won't want to write an advanced care plan. They find that too difficult, or they just don't believe that it's appropriate to make decisions at this point in time for the future. But they can choose someone to speak up for them if ever in the future they were not able to speak for themselves. So that person is called a substitute decision maker. There's a website there, www.advancedcareplanning.org.au, that provides a lot more information around all of this. Advanced care directives. So all states and territories in Australia, except New South Wales and Tasmania, have statutory advanced care directives. The names of these documents actually differ between jurisdictions, but the scope of what can be included varies as well. All the documents can include information about refusal of treatment, as well as what the patient would want to accept. When treatment is refused in writing, it can be for all treatments or for particular treatments. For example, somebody might say that they don't want resuscitation in the event of a cardiorespiratory arrest, or they might say they don't want to be treated on an intensive care unit, or it might be as simple as they actually don't want antibiotics if they develop an infection. So they can be quite specific. I'll just take a moment to show you a website. So here we are. Here's the Advanced Care Planning website, and that's on the bit that is relevant to Western Australia. And you can see there that you can actually view the various forms, and it'll take you through some guidance in regard to how to complete those. Okay, so some considerations. Initiating the discussion. As we've said, help them think about what's important for them in life based on their values and also their goals. What are the things that they still want to achieve? Think about the various medical treatments that might be available to them and the range of outcomes that might be achieved with those treatments. And then again, it's about thinking about where those trade-offs lie for that individual person between potential side effects or adverse effects of treatment and the potential benefit. And actually encouraging people to speak to as many different people as possible before they make firm decisions about that can be useful. These documents then are living documents. It's an ongoing conversation, and we should be reviewing these discussions at regular intervals, and particularly if there's a change in the person's circumstances, whether that's due to illness progression or due to a change in their social situation, for example. We also need to make sure that these plans are accessible and that key people know where the plans are kept and how they can be accessed, and actually patients should be encouraged to store this information on their health record. There's some more information there that you can access as well. Helping people to choose a substitute decision maker can also be quite useful. It isn't always immediately obvious who that substitute decision maker should be. It might be somebody in the immediate family, but actually they may feel that those people are either vulnerable or would be too distressed to make those decisions on their behalf, and they may choose to involve a professional or somebody who's a trusted friend, for example. So the substitute decision making can be anybody that they trust who believes that they would make decisions appropriate to their wishes. They should ideally be somebody who's living very close to the person and available, likely to be available at the time that those healthcare decisions need to be made. They need to be an adult, and they need to be able to communicate clearly and confidently on the person's behalf. People can actually legally appoint someone using a form, and again, dependent on the state or territory, the termination around that can be different. Terminology, around that can be different. In Western Australia, it's appointing an enduring guardian. So, when and how do we initiate advanced care planning conversations? I think the answer to that can vary. The ideal answer is as early as possible in somebody's life, and certainly at a point when they develop what looks as though it's going to be a progressive illness that may result in death. And you initiate those discussions just by talking about what's important to people. How do we ensure that advanced care plans are current and accessible? Again, that's about having a plan for regular review and thinking about the triggers within a disease progression that might actually trigger those reviews. And also making sure that information is communicated to as many people as possible, both professionals, family, friends, and so on. So having talked about planning ahead in the context of a disease where we've identified somebody who may have palliative care needs and we've thought about their disease trajectory, we're now going to go on to part 2 of the presentation. So we're going to think now about assessing and managing common symptoms. Here are the principles for symptom assessment and management. It's about recognising the etiologies of common symptoms, which we know in people with advanced disease are often not straightforward. There's often several things that are contributing to a symptom pattern. And understanding the underlying etiologies will actually help us to decide what treatment approach is the most appropriate. We need to think about what's reversible and what's not, and how that's going to impact on our management. We need to think about the person holistically and not just focus on the symptom alone, but we also need to be planning ahead and thinking about what problems might occur in future and how can we plan to have a clear plan of management for when they do. We need to think about the treatments that we have on offer and the potential benefits, but also the potential burdens to the patient, and understand actually from the patient's perspective where that balance lays, and that can be different for every individual. We need to think about where the person is in the course of their illness and whether or not particular interventions are relevant, and we need to think about the overall goals of care of the person and their wishes. Some people will want to keep things very simple, others will want any intervention that may have some chance of benefit regardless of the potential burden. So there's a whole spectrum, and we need to understand our patients. We also need to cease treatments that are no longer beneficial. And I think that's something that actually we spend a lot of time in specialist palliative care doing, often at the point where we're assessing patients, where, for example, stopping agents for hypertension, where somebody's prognosis is very short, stopping their statins, the sort of things that we do to prevent problems in the future that become less relevant when somebody's got a very short prognosis with an advancing illness. But also patients can collect a number of different analgesics or antiemetics, for example, because people tend to add in when symptoms are poorly controlled, and there's a tendency not to withdraw the things that haven't helped once symptoms come under control. So we need to be very mindful of that. We also need to constantly reassess and think about referring to specialist palliative care if things are complex or can't be controlled. The thing I'd say there is, in terms of defining complexity, it's anything that feels beyond your level of comfort and confidence. So that can vary for different practitioners. And I don't think you'll find a palliative care team out there that won't welcome a referral if you feel you're struggling. So I would say, err on the side of phoning somebody, asking a question, or making a referral if you think that might be helpful. So we'll go on to talk a little bit about pain management now. And I guess the first point of thinking about pain is actually defining what pain is. Pain is a very subjective symptom, but it can be described as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. And that definition brings in the emotional experience that comes with pain. And it can be a highly emotional experience. And actually somebody's emotional reaction to pain can have a big bearing in how they represent pain, and how much distress the pain itself causes. Just because people can't communicate verbally doesn't mean that the individual is not experiencing pain. So we need to be thinking about how we assess pain in people who can't communicate it easily. So here's another useful mnemonic which can be helpful in the assessment of pain. OPQRSTU. O is for origin. Where is the pain? Where is it located? And onset. How did the pain start? And when did it start? P is for palliative and provocative factors. What makes it better? What makes it worse? Q is for quality. What's the pain like? Describe what you feel. Describe how it makes you feel. R is for radiation. Where does the pain move to? Or related symptoms. What other symptoms do you experience when the pain occurs? For example, sweating or nausea. S is for severity. People will often there bring in pain scores, a scale of 0 to 10, where 0 is no pain at all and 10 is the worst pain that somebody can imagine. Some patients find it very difficult to allocate a score to pain, and some people get very fed up with repeatedly scoring their pain. I prefer to ask people how the pain is interfering with function or their enjoyment of life, because then you can assess the severity in terms that the patient really understands. T is for timing. How does the pain vary over time? For example, during the course of a day or over a number of weeks. U is for understanding, which again is important, and that brings in the holistic part of the assessment of pain. What is the meaning of this pain to you? Sometimes when people experience severe pain, they worry that it means that death might be imminent, and actually simple exploration of that can allow reassurance. Also think about examination to further assess the pain. Look for tender areas, look for lumps and bumps, look for areas of abnormal sensation. And particularly that last one can help you to understand what sort of pain the patient's experiencing, both the descriptors in the quality. For example, with bone pain, it's often a deep ache and actually sensation is preserved. Whereas with nerve pain, you may find people describing pins and needles or burning sensations, or just sensation that doesn't feel quite right. There's an area where the sensation isn't normal and there's pain in that area. This mnemonic can actually be used with minor adjustment to assess any symptom. For example, nausea. And if you work through that, if you omit origin and radiation, you can see that with the rest of that history, you could actually describe nausea. It might be, for example, with the quality, that particularly when you're asking whether somebody's feeling sick or being sick, if they're being sick, you need to understand the quality of what they're actually producing. And that can help understand what the cause might be. For example, is it feculent matter? Are they getting acid reflux? Are they bringing up large amounts or just water brash? That can all help you understand the underlying problem. So going back to pain, and let's think about pain management. Opioids are the only pharmacological class of drug with the ability to control severe pain. We always like to use the oral route first line where possible because it's straightforward and it's the route we're most familiar with. We should use regular doses with controlled release preparations where somebody's got persistent pain, and we should encourage the use of PRN or immediate release medications where people have pain that occurs in between those regular doses. As a general principle, for morphine and oxycodone and hydromorphone, our immediate release dose would be 1/6 of the total daily dose of the opioid that we would use then for any breakthrough pain. We titrate the background dose against effect and also against toxicity. And sometimes if somebody is getting benefit from the opioid, but actually is developing side effects that preclude us titrating further, we can switch to an alternative strong opioid, and people will sometimes tolerate a different opioid better. So that then allows further titration. That can be quite helpful. But we do also need to think about whether we've got the right underlying cause of pain. For example, if we're treating neuropathic pain with opioids, we're going to find that somebody develops toxicity before they've achieved pain control. And we need to think about whether we need to add in an agent specifically for neuropathic pain. So the World Health Organization principles for analgesic use are that we should give analgesia by mouth, the oral route is preferred. By the clock, we should give them regularly, and also think about using something in the background where pain has been persistent. And by the ladder, and by that they mean the analgesic ladder, which is a 3-step ladder with paracetamol and non-opioids on the first rung of the ladder, weak opioids such as codeine, tramadol on the second rung of the ladder, and strong opioids such as morphine, oxycodone, hydromorphone, fentanyl on the top rung of the ladder. So we step up that ladder according to the person's response, and at any point during that escalation, we can actually introduce adjuvants for pain control. So when we've got someone with mild to moderate pain, we may be able to control their pain with paracetamol or anti-inflammatory drugs such as non-steroidals, diclofenac, ibuprofen. Non-steroidals are particularly good for pain that's related to musculoskeletal injury or any cause of pain that has associated inflammation. For people with moderate to severe pain, we're likely to need an opiate. And we might try first off with just an immediate release preparation just to assess how the patient responds to that pain, and progress fairly quickly to introducing a background dose of modified release. And we're going to need a combination of both ultimately to achieve the best pain control. We might want to think about co-analgesics, as I've said, where we're suspecting neuropathic pain. For example, introducing something like pregabalin or amitriptyline alongside. And there is no evidence that says that either of those is better than the other. So it's really thinking about comorbidities and other symptoms that those agents may help. When we're thinking about second-line treatment, if pain isn't adequately controlled, we can look at how many breakthrough doses the patient's actually needed in the last 24 hours. So if they're needing more than a couple of PRN doses of opioid in 24 hours, we're probably going to need to increase the background dose. And we would go up to 50%, usually 30 to 50% is the increment that we would use with the background opioid. And we shouldn't really be increasing that background dose more often than every 2 or 3 days. Otherwise, we're likely to find that the patient develops intolerable side effects. So sometimes during that escalation, if we're going up a bit faster and the patient develops hallucinations, drowsiness, confusion, we just need to go back to the last dose they tolerated and titrate a bit more slowly. But we can also think then about where the first line treatment isn't working so well, whether or not we might need to add in adjuvants. For neuropathic pain, but other co-analgesics can also be helpful. We might want to think about steroids or anticholinergic drugs, for example, for colic or bladder spasm. So CareSearch is a website that you can access that will give you some guidance as well on the use of opioids. The CareSearch website is actually really good. If you go and have a play on this at some point in time, you see all the latest evidence for various different clinical interventions. And it's a really good source of getting all of the evidence in one place. So you'll find the original references and data sources on the website as well, and they'll give you links to those papers. So very good resource, CareSearch. Okay, so let's begin to think about the different opioids that we have available to us. Morphine's been widely recommended because of its efficacy and its easy availability. It's easy to use, it's cheap, and actually people have a lot of clinical experience using it in palliative care patients. But there's no evidence that one opioid is superior to another. So we have options available to us. Morphine, oxycodone, hydromorphone are all very similar clinically in regard to their efficacy and their adverse effects. So the choice of opioid might be based more on the individual that we're treating, whether or not they've had experience with other opioids in the past and whether they've tolerated them, whether they've worked, thinking about the various different preparations that the different medications have available. For example, looking at liquid forms versus tablets, once daily versus twice daily, and so on. Thinking about the cost to the patient and to the healthcare system. So there's a lot of flexibility there. One thing I will say is oxycodone is available as a compound preparation with naloxone as Targin, which is a long-acting medication given twice a day. Targin can be very good. The addition of the naloxone in the Targin preparation, there's good evidence that there's a lower incidence of, for example, constipation with that preparation compared to slow-release oxycodone alone. However, if you have somebody who develops liver metastases and impaired liver function, actually you can find that the analgesic effect of the oxycodone reduces because you don't get the metabolism of the naloxone peripherally. So you need to be very careful of that. So we need to think about things like that. We've also got available to us preparations such as methadone and transdermal preparations such as fentanyl. We don't recommend that they're used first line in most circumstances, but there are some situations in which we might. For example, you might use transdermal fentanyl first line in somebody who's undergoing dialysis or who's got bowel obstruction. Methadone is quite a complex medication to use and is specialist use only. It does have some benefits in terms of some additional actions that mean it can be helpful in neuropathic pain as well as somatic pains, that's bone, soft tissue pains. So when we're thinking about starting opioids, the starting doses for somebody who's opioid naive would be oral morphine, 30 milligrams over 24 hours for somebody who's got moderate to severe pain, or 60 milligrams for 24 hours for somebody who's already using a step 2 opioid. So that's somebody who's already on codeine, for example, at maximum dose, who's still got moderate to severe pain, then we need to step up. We should divide the dose into either a once daily or twice daily preparation. according to the particular preparation we choose. And if we're giving immediate release medication, that can be given 4-hourly in the titration phase before we introduce a long-acting opioid, or 4-hourly PRN alongside a long-acting opioid. Patients often need reassurance about the use of opioids in cancer pain. They've often heard of opioids, they're often quite anxious about them, they worry that they'll become addicted, and there's no evidence that people become addicted when they're using opioids in a titrated manner for pain, rather than people who will abuse opioids and use them for the buzz, in which case they do obviously run the risk of developing addiction. People will often worry as well that they need to save the dose for when they become less well, and that they worry that pain relief will become less effective as their disease progresses. Again, that's a myth. And actually, there is no top dose of opioid. And as long as a patient is responding to the analgesia, we can continue to adjust the dose appropriately as disease progresses. We also need to think about the side effects of opioids, particularly constipation, which is the most common side effect, and patients should be given a laxative as they commence strong opioids. It's also worthwhile giving them an antiemetic to use if they need it. About 30% of people will feel quite nauseated when they commence a strong opioid for the first time, but usually that nausea is fairly short-lived, and if they can take the antiemetic for the first week of using the strong opioid, they should find that they are able to withdraw it and that the nausea does not persist. It's a very small proportion of people who would actually have persistent nausea beyond that first week. You should also note that about 10% of the population are unable to metabolize codeine to morphine, which is the active form of codeine. So if you have got people on that step 2 of the analgesic ladder and you're concerned about toxicity, you might want to use a more cautious conversion. So rather than jumping straight to 60 milligrams of morphine in 24 hours, you may want to perhaps go to half of that, to the 30 milligrams, and titrate up. So as we mentioned before, in most cases when we're thinking about that as required dose of short-acting opioid alongside the long-acting opioid, the recommendation is that we would use 1/6 of the total daily dose. So for example, for somebody who's on 30 milligrams twice a day of long-acting morphine, we would then look at 5 milligrams as their PRN dose. Again, if we want to be more cautious, we can actually, there's a school of thought that suggests you should start with 1/12 rather than 1/6 and actually titrate the PRN dose. And I have to say that can be quite helpful, particularly in the elderly or people with impaired renal function. You may have come across transdermal fentanyl, that should be transmucosal fentanyl lozenges as well for breakthrough pain. You can also now access transmucosal fentanyl tablets. These are an alternative for use for breakthrough pain. They tend to have a faster onset of action, but also a faster offset of action. So whereas PRN morphine, oxycodone, hydromorphone will be effective within about 30 minutes and will last about 4 hours, the transmucosal fentanyl preparations will act fairly quickly within minutes, but will also only last an hour or 2. So sometimes that can be quite helpful dependent on the type of pain that the patient's experiencing in between. So for example, if you've got somebody with pain specifically on movement where you want that benefit quickly, but if they sit down and rest, the pain resolves. So you want something fairly short acting, the transmucosal fentanyl preparations can be very helpful there. One of the things that it's important to note with these preparations is that there is no dose conversion with those in relation to the background dose of morphine, oxycodone or hydromorphone. So you do have to titrate from the lowest dose, 100 micrograms, and titrate with the individual. If you're using morphine, oxycodone, hydromorphone on an as required basis, then again, when we're titrating, we would think about dose increments of 25% for PRN use. I talked earlier about the fact that sometimes we can switch from one opioid to another if a patient is experiencing intolerable side effects. One of the things that's important to note here is that you'll come across lots of different dose conversion tables, and the ratios are not fixed. And that's because actually the evidence shows that there can be a wide range of conversion ratios, so they're only approximations. And really you need to use some clinical judgment when you're thinking about these dose conversions, and be prepared to be cautious with people who may experience more side effects. Again, I will just show you here. On the WA Department of Health website, you can actually access this opioid conversion chart. So you can just Google Department of Health opioid conversion and it will take you to this chart. So that tells you how you would convert from morphine, for example, to hydromorphone. Hydromorphone is 5 times more potent than morphine, so we would only need 1/5 of the dose. So when we are switching opioids, it's really important that we review the patient regularly, and fairly soon after the conversion ideally, and that we continue to reassess both the pain and the adverse effects of medication, just to make sure that we're on the right tracks. When we're thinking about the route of administration of opioids, we have a number of options available to us. We've talked about the fact that the oral route is generally the most preferable, but we know that the subcutaneous route of administration is also effective and safe, and actually it's much easier than intravenous administration of opioids, particularly in a community setting, and you don't have the same problems you have with needing cannulation or the risk of infection. It's much less with subcutaneous route. So we can use subcutaneous route for PRM medication and also for continuous infusion via a NICI pump. The rectal route is also something that we have available to us, although it's less accessible through pharmacists, and actually often less acceptable to the patient as well, so much less commonly used. Transdermal opioids, such as fentanyl, are a non-invasive option for patients who are unable to swallow. So that's an alternative to a NICI pump. They're particularly useful where somebody's got stable pain control with an oral preparation perhaps, and where they become unable to swallow, you can make that conversion. So what you would do there is you would give your last dose, ideally of long-acting medication, at the same time as you apply your first fentanyl patch. And that allows the patch to build up in the system, because it's going to take probably somewhere between 24 and 72 hours for the patch to reach its full efficacy. So by covering with that last dose of oral long-acting opioid, you provide that pain relief for the patient. I would always say to people that during that conversion, they need to be prepared to inform somebody if they've got pain and to take PRN medication, because there may be some instability of pain control during the conversion. We also know that with transdermal opioids and Targin, as I've mentioned before, the constipation may be less. So fentanyl can have some advantages from that point of view, and again can be helpful in people who may be prone to bowel obstruction. So people with bowel cancer or disseminated ovarian cancer, for example, might benefit from the use of transdermal fentanyl rather than other opioid preparations. We should also think about non-pharmacological treatment of pain. What we know, we've already talked about the fact that pain is an emotional experience as well as a physical experience. And actually, there are a number of things we can do that can adjust somebody's pain threshold. So they might have the same level of physical pain, but they cope very differently with that physical pain. Sometimes that can be as simple as talking somebody through what the underlying cause of the pain is and having those treatment strategies up their sleeve. We can also look at more complex interventions such as cognitive behavioural therapy, simple things like relaxation or distraction with music or activity can be beneficial for some people as well. There is also some limited evidence of the benefit of interventions such as TENS, reflexology and acupuncture. So I talked earlier, when we were talking about the analgesic ladder, I talked about adjuvants that can be used along the way. So adjuvants should be added when pain is not fully responsive to opioids. I mentioned both antidepressants and anticonvulsants for neuropathic pain. They can certainly be helpful, but sometimes we need to just be aware that there's a reasonable likelihood of adverse side effects, particularly drowsiness. So we need to be cautious again with titration. Start the dose low, titrate it slowly every 3 or 4 days, I would say, is the minimum interval with dose titration. And again, keep checking on your patient and see how they're tolerating the medication. Sometimes you can find as well that if you introduce these adjuvants for neuropathic pain and the pain resolves, people can develop opioid toxicity. So actually, if pain comes under control and the patient is drowsy, for example, you might want to reduce the background opiate a little bit. External beam radiotherapy can be effective for people who've got metastatic disease that's causing pain, particularly bone metastases, but sometimes soft tissue metastases causing pain as well, and can be helpful at various stages. Sometimes as you introduce opioid analgesia, you can offer radiotherapy and you may be able to withdraw opioid analgesia later. Sometimes people prefer to manage with the pain relief and only use external beam radiotherapy if analgesia alone is not resolving the pain. Obviously, a patient needs to be well enough to attend and close enough to a centre that can offer radiotherapy to be able to do that. Bisphosphonates can also be helpful for bone pain. There is some good evidence for that, but you do need to be aware that if the patient's got renal impairment, bisphosphonates may be contraindicated or the dose may need to be reduced. And also you need to check dental health because otherwise you can run into problems with osteonecrosis of the jaw with bisphosphonates. The analgesic effect as well with bisphosphonates is not something immediate. It will be of benefit over days rather than hours. Non-steroidals, as we've said, are effective for musculoskeletal pain particularly, or any other inflammatory cause of pain. And other adjuncts may include steroids. For example, if you've got somebody with liver metastases and liver capsule stretch, or brain metastases and headache, or neuropathic pain, again, steroids can sometimes be helpful by reducing the compression on a nerve. Buscopan for colic or bladder spasm, antacids for somebody with dyspeptic abdominal pain. So, key considerations when prescribing opioids. We've talked about these. The oral route is preferred, but if the patient's unable to swallow or you've got a compromised gastrointestinal tract, you can consider transdermal patches or the parenteral route, most commonly subcutaneous. If the patient's got impaired renal function, we should avoid morphine, or we can use very low doses much less frequently. It's much more likely to accumulate. Oxycodone and hydromorphone can also accumulate. Hydromorphone less so, but you do need to beware. When somebody's got severe renal impairment, then fentanyl is probably your best option. Buprenorphine for patients who are sort of needing relatively lower doses at the sort of lower end of the pain spectrum, and methadone for people who've got more complex pain. As I said, that needs to be introduced with specialist supervision though. When people have got impaired liver function, we need to stop targing, and you need to be cautious with oxycodone. People rarely develop allergy to opioids, but they will often tell you that they're allergic to opioids, and it's usually that they've developed adverse side effects, particularly nausea and vomiting, or drowsiness, or hallucinations. But if it is a true allergy, then we should be rotating to opioids of a different class. So, for example, switching morphine to oxycodone. If somebody's got severe constipation, ileus, or bowel obstruction, we should be looking at using the fentanyl patches, which may be less constipating, or targin, as we said, may be less constipating, and sometimes parenteral formulations can be helpful. Morphine should be introduced cautiously in the elderly. I think that's probably true of most strong opioids. But certainly for people who may have impaired renal function, we need to go cautiously with morphine, starting at perhaps half the dose as you would with a younger, healthier person. Buprenorphine patches can give a continuous subcutaneous absorption of low dose opioids, but there are limitations there because buprenorphine's a partial agonist, so there is a ceiling dose with buprenorphine, unlike the other strong opioids. For people with cognitive impairment, once daily formulations that they don't have to remember as often, or the transdermal preparations can be helpful because somebody can put those on and come back a few days later to replace the patch. Tablets and capsules that can be put in a Webster pack so that people have got something, if they've got sufficient cognitive function to actually use the Webster pack, that can be helpful. Again, somebody who is just forgetful or poorly compliant, the transdermal preparations can be useful in that situation. You do need to be careful with cost. Not all opioids are subsidised by the PBS. Most of the common ones are, but you would need to refer to your PBS for that. And obviously in some areas there are different levels of availability of some opioids, and particularly in different countries there are differences. You need to think about that if you've got a patient who's travelling with strong opioids and their accessibility to medication whilst they're away. So the key thing here is actually for you to become familiar with a small number of opioids and develop your confidence with using them. Patients are going to be safest if they're using medication that their doctor is familiar with. I think that's really important. But if you think that a patient might benefit from rotation to an opioid that you're less familiar with, then your pharmacist or palliative care team or a pain specialist will be very happy to support you. Okay, so let's just run through some cases, and then we can perhaps see some of these points that we've made illustrated in practice. So here we have a 78-year-old lady who attends a clinic appointment. She's got end-stage renal failure secondary to diabetes and is on dialysis 3 times a week. She's got a new diagnosis of breast cancer with painful bony metastases. So what might we think about for pain relief in this situation? We obviously need to be careful with the renal impairment. So whereas we've said that for bony disease, non-steroidals might be helpful, clearly we're not going to want to introduce non-steroidals in somebody with renal failure. As we've discussed, fentanyl patches are probably the best option for somebody with persistent pain with end-stage renal failure. So we might want to introduce a low-dose fentanyl patch in this lady, and perhaps with hydromorphone as required. And we would use those conversion tables to think about the appropriate hydromorphone dose for somebody on a 25 microgram per hour patch, for example. We would just want to use low dose hydromorphone, maybe just 1 milligram. We've talked about the fact that switching opioids and changing routes or medications is actually quite common in palliative care because people do run into difficulties. The sorts of things the reasons that we would switch opioids would be the following. Either that we're unable to achieve adequate analgesia with a particular opioid because of side effects, or hyperalgesia. So you can get situations, particularly with morphine, where as you escalate the dose, the pain may not come under control in the area that you're trying to treat, but people just become generally sensitive, even to things like joint movements, all over pain. Everything just feels a bit sensitive. So then you would want to withdraw that opioid and try a different one. Development of toxicity and intolerable side effects, most commonly drowsiness or intolerable constipation, but also people may develop confusion, myoclonus as well, something that would be a trigger for us to think about an alternative analgesic. Or somebody might develop a change in clinical status, so they develop swallowing difficulties or malabsorption or bowel obstruction or new renal or liver failure. Or if we develop a concern about potential drug abuse, we might also then want to consider alternative options. And we can look at, for example, matrix fentanyl patches in that kind of situation. We would also want to think about drug interactions. So where new medications have been introduced, we may need to review our opioid choice. And we need to think about financial and drug availability. Okay, so we have a question. Thank you, Peter. Starting fentanyl first, do you run the risk of getting rapidly escalating tolerance too early or reaching a high dose limit? Certainly fentanyl has more challenges if you're somebody who's got very high analgesic needs, because obviously you're limited in your top dose with a patch to 100 micrograms per hour, and then you're limited with practicality with the number of patches that you can apply. We generally tend to find that actually it's a good option, and for most people we can manage their pain within the practicalities of using fentanyl patches. Very occasionally, if we're getting to those certainly more than 300 micrograms per hour of fentanyl as somebody's disease progresses, we might need to look at using some subcutaneous analgesia alongside, or perhaps rotating to methadone if it's a patient who can manage oral analgesia, or we can use methadone in a syringe driver as an alternative. So where we're getting to very, very high doses of morphine, oxycodone, fentanyl, then methadone can be a good option for just rationalizing their opioid use. Sometimes we can get away with much lower doses and more practical doses. Thank you. Okay, so I talked a little bit about opioid conversion previously and said that there are a number of different tables that exist out there if you search for them to aid conversion. There is the one that's recommended by WA Health, as I say, which is a good one, but this is also a website that you can access that will allow you to populate that with the opioids that you're currently using and what you're currently using for breakthrough, and allow you to select an alternative opioid and give you an appropriate dose. So that's a useful resource for you to be able to use. And here within the presentation, you can see the dose conversions on this table are the same as the one that's recommended by WA Health. This one's actually from Queensland, just looks a bit different. So we can see the common conversions here. For example, morphine to hydromorphone is that ratio that we talked about before, where we would divide the morphine dose by 5 to get the hydromorphone dose. It is important with these tables that you take time to really work through some examples. It isn't unheard of for people to actually apply those ratios the wrong way around. And obviously, if you multiplied a morphine dose by 5 to get 50 milligrams of hydromorphone, you've got potentially a massive overdose on your hands. So you do need to be a bit careful, and you need to familiarise yourself with these tables and actually how to use them. And here for the more tricky conversions, where you've got morphine to buprenorphine or fentanyl, or the other way around, you've got some guidance there. Okay, and that's the online opioid conversion calculator that we've discussed. So, case 2. 85-year-old lady who's in a residential aged care facility. She's a lady with advanced metastatic colon cancer and dementia. She's got cerebral metastases and has had previous seizures and is entering the terminal phase and is unable to take her morning medications. So she's been on OxyContin, 30 milligrams twice daily, metoclopramide, 10 milligrams TDS, phenytoin, and levetiracetam. So we need to think about what we would do with this lady. She's not now able to use the oral route for medication. So my suggestion would be here that we would think about beginning to give this lady medication through the subcutaneous route, and ideally with a subcutaneous infusion. I would convert the OxyContin there to hydromorphone. And I know from experience and using those tables, you'll be able to work through to find that 30 milligrams of oxycodone twice a day is 60 milligrams in 24 hours. Therefore, the 24-hour dose of subcutaneous hydromorphone would be 6 milligrams. I would also put 30 milligrams of metoclopramide in the syringe driver. And to prevent seizures, as she'd be unable to take the phenytoin and levetiracetam, I'd use 10 to 15 milligrams of midazolam. Our third case, 62-year-old male, Friday afternoon appointment. They're always the best ones. This chap's got a squamous cell carcinoma of the tongue. He's got increasing swallowing difficulties because of mucositis from radiation treatment. He's managing fluids, but he's struggling to swallow tablets. He has an appointment the following Monday for PEG insertion at the hospital and would prefer not to be admitted to hospital over the weekend. He's been taking MS-Contin 100 milligrams twice a day and paracetamol tablets. So this is a chap who, again, is not going to manage the oral route over the weekend, and we need to think about what we do. So we need to think about our options here. And if we go back to here, we can see that 200 milligrams of oral morphine would be equivalent to 50 micrograms per hour of fentanyl. So one option would be there to consider applying a 50 microgram per hour fentanyl patch if he was able to take that last dose of long-acting morphine to cover the first 12 hours or so of the patch administration. An alternative otherwise would be to look at using the parenteral route, and then to sort out the conversion from that point of view, you could use subcutaneous morphine at a third of the total oral dose. So that would be roughly 60 to 65 milligrams of morphine over 24 hours. And the paracetamol, we might want to try and access some paracetamol liquid. So, in terms of managing pain in patients with advanced illness, there are a number of things that can make that quite tricky. Firstly, it can be, as we talked about at the beginning, that actually symptoms often have multiple etiologies, and actually patients with pain with advanced illness often have more than one pain, and they can be pain that have different origins. So they might have one neuropathic pain, they might have one bony pain, they might have some soft tissue pain, and they may have pain that's difficult to characterize. So sometimes they will need more than one agent to help their pain. We also have to think about the biochemistry. People with advanced disease often have progressive renal impairment or liver impairment or change in biochemistry, which can make things more tricky. Somebody with rapidly escalating pain may have something else going on. For example, somebody with back pain whose pain gets suddenly a lot worse might have a spinal cord compression or hypercalcemia, and we need to have some awareness of those things as potential problems. So things can be tricky, and we have to think about drug interactions because often people are on multiple medications, and we have to think about the route of administration. When prescribing opioid analgesics for patients, we find that the sorts of things that tend to make people anxious about prescribing opioids is firstly that it can be unfamiliar territory. It might be something that you don't do often, and particularly not in these kind of complex circumstances. We know we've got a number of different medications available to us, and actually you may not be familiar with some of those options, and you may need assistance. People sometimes have their own fears about opioids as well. So it is important to understand, for example, that opioids can be perfectly safe in somebody with COPD. That's often a concern for professionals. But actually, as long as we start doses low and carefully titrate and monitor the patient's condition, that's usually not a problem. We do need to think about monitoring for side effects, and sometimes it can be a worry when you've got a patient at home and you're not able to perhaps see them as quickly as you'd like to for review. So it's important there to give the patient and their family some parameters, things that they can monitor for, and some instructions about what to do if they run into difficulty. Let's look at our fourth case. 52-year-old man with metastatic lung cancer and bone metastases. He's been taking MS-Contin, 30 milligrams twice a day, paracetamol 1 gram 4 times a day, and Caloxyl and Senna 2 tablets twice a day. He says he's pain-free at rest, but as soon as he gets up to move, he gets pain in his back and ribs, and that increases rapidly to reach 6 out of 10. He says he's been feeling a bit sleepy, but otherwise has no side effects from the morphine. So here we have to be a bit wary because he's already got some background somnolence, and if we use a lot of PRM medication each time he moves with his back pain, we may actually make him more sleepy, particularly if we use those PRM medications that might hang about for 4 hours. So PRM morphine. Here our PRN dose, being a sixth of the total daily dose of morphine, would be a sixth of 60 milligrams in 24 hours. So the PRN dose that this chap might be using would be 10 milligrams. But if he takes 10 milligrams, he'll have to take it a bit before he gets up to move, so that, you know, certainly if he's planning before he gets up in the morning, he might want to take his morphine, and then it'll be in the system when he starts to get going, when he's having his morning wash and so on, so he might be able to tolerate that better. But the morphine's going to hang around for around 4 hours, so we just need to be aware it may make him feel a bit more sleepy during that time. That might be acceptable, he might tolerate it, might be a reasonable option. But here's one of those instances where we might want to think about the transmucosal fentanyl. So we might want to try him with 100 micrograms of transmucosal fentanyl, and that can be repeated after 15 minutes if need be. Or you could use the lozenge, and he can stop using that as soon as the pain is under control. So that would be another option here, and that's quicker acting, and it hangs around for less time. So when he stops moving, it's out of his system, and it's less likely to make him sleepy. We might also think here about the fact that if he's been a bit sleepy with his 30 milligrams twice a day of morphine, we actually might want to rotate him to an alternative opioid. We might want to think about OxyContin or Genista, for example, just as alternatives there. So here we've said we want to think about preemptive breakthrough medication, as we said, you know, before he gets up in the morning, take the pain relief first. That might help him manage to do a lot more movement without pain. If we just increased his background dose of morphine, we're likely to make him more drowsy. So that really isn't the solution here, because we've got a specific precipitating factor for his pain. We could think about lifestyle modification, telling him to move less, or perhaps review by a physiotherapist or occupational therapist. They might be able to provide equipment or show him different ways of doing things that may mean he can do more with less pain. So those things are also important to consider. We could think about some radiotherapy that might help his pain as well. And we could think about options such as non-steroidals or a trial of steroids, which may also help his back pain. And as I said, if you've got somebody with rapidly escalating back pain in these sorts of situations, do check their calcium. It's the thing that people forget. But anybody with rapidly escalating pain, and certainly with drowsiness, I'd want to be checking their calcium to see if they were hypercalcemic. You'd also want to be checking their neurology, their bladder function, their bowel function, and thinking about whether or not they might have core compression. So here you've got some key references that may help you, things that you can access to as guidance for your management. I'm just going to move on now to managing the terminal phase. I'm aware that we've only got a few minutes to go of the webinar. So, the most effective end-of-life care is provided when there's skillful communications with patients and families about realistic goals of care and attention to understanding the patient's and family's concerns, as well as competent symptom management. So the communication here is key, and actually having realistic goals is also key. Never promise a patient that if you refer to specialist palliative care, they'll be able to get them pain-free and free of nausea and vomiting, because actually we may not be able to. We don't have a magic wand, but we can certainly look at minimising symptoms and actually helping people to have a better quality of life and to have ways of managing symptoms that occur. So, in order to achieve the goals that are important to patients and families and provide good end-of-life care, we must identify that a patient is imminently dying. Sometimes difficult to identify when a person is close to the terminal phase with a prognosis of days to weeks, but where possible, this knowledge may be of great value to patients because they can reorient their priorities. So the sorts of things we might want to think about there: somebody who's spending more time in bed, more time asleep, who's perhaps less able to eat and drink. Certainly as somebody becomes more and more unwell, they may develop respiratory tract secretions where perhaps by that stage we've only got hours to live rather than days. And all of this in the context of advancing illness and something that's not reversible or that the patient has chosen not to have treated. So the principles of prescribing are as they are really earlier in the illness. We need to still pay attention to that assessment of symptoms and other problems. We need to be thinking about proportionate treatment for symptoms, so we don't just wade in with big doses because somebody's nearing the end of life, because we're more likely to cause side effects. We need to think about the burden of those potential side effects and try and minimise them. We also need to think about the route of administration, and often we'll need the subcutaneous route at this stage. We still need to think about regular medication or infusion rather than just PRN. But we should also be thinking ahead and making sure that PRN medications are prescribed for potential symptoms at the end of life. And the things that are common: pain, nausea and vomiting, agitation, restlessness, general distress, respiratory tract secretions. Those are the sorts of things that are very common. Patients with brain metastases may experience seizures, or people with electrolyte instability. Not very common at the end of life, but may occur, and we should make provision for that in PRN prescribing. People who've had hemoptysis or PR bleeding, for example, we might want to write up a crisis order for a bigger dose of midazolam, say 10 milligrams of midazolam subcutaneously or IM ideally, as long as their platelets are okay, so that actually if they develop a big bleed, we can alleviate that distress quickly. And we can give midazolam by the buccal route as well, the intravenous preparation by the buccal route if need be. That's a useful tip for managing things at home. So let's think ahead and have those things prescribed PRN for just in case. Think also, if somebody's distressed and agitated, about developing urinary retention, because that's a commonly missed problem towards the end of life that causes a great deal of distress. Plan ahead for access to medications for these common symptoms, so that we're not trying to obtain them at a time when somebody's very distressed, that they're already there and available in the home. Palliative sedation should be the last port of call. So if we've got somebody who's very distressed and we're unable to manage their symptoms adequately, we can think about palliative sedation with the engagement of appropriate clinicians and discussion with the patient and family. But again, that sedation should be proportionate, and we should use the lowest possible doses to alleviate distress. So here's just some indications and advantages of subcutaneous infusion devices that we commonly use towards the end of life. It does give us a route when people can't take oral medications or have got problems with nausea and vomiting, dysphagia, malabsorption, or they're less conscious and less able to swallow. And so sometimes we can use the subcutaneous route for very acute symptoms that we want to stabilise, so that we can understand the baseline medication needs and then convert them to regular oral medication. Subcutaneous infusions are less invasive than other parenteral routes. There's less risk of infection, as I said, can help comfort. They're usually very well tolerated and easy to have around at home. They do need daily refilling though, but we can administer a combination of medications that way. Let's just talk about Harold. He's a 90-year-old gentleman who had a bad fall, transferred from hospital to hospital from home, and was cared for by the emergency team. He has a past history of dementia, AF, renal failure, depression, hypertension. He'd been discharged from hospital following admission after a fall with no injectable forms of pain relief or other palliative care medications. He's no longer able to swallow oral medication. It was clearly documented from hospital, and the family were aware that the goal of care was to keep him comfortable. The family understand that he's close to the end of life, and he's also requested that his body be donated for medical research. With his fall, he sustained a subdural hematoma and some left-sided rib fractures. So this poor chap's obviously in quite a bad way. Fracture of his left distal clavicle as well. I think the key thing here for me is that actually when somebody comes home and it's clear that our goal is comfort care, we really need to have those medications available and prescribed so that they can be administered. And actually our goal should be to keep this man at home if home is where he wants to die, and we should avoid that unnecessary admission to hospital. So his medications: oxycodone just on a PRN basis, mirtazapine, digoxin, aspirin, risperidone, and irbesartan. He's got an acute confusional state. He's hallucinating, febrile, doesn't look well, bedbound with lots of bruising, laboured breathing and hyperventilation, and bilateral pleural effusions. So they may or may not have been present previously. So here we've got a chap who's really quite distressed. We've got potential multiple causes for his acute confusional state, including potentially digoxin toxicity, potentially opioid toxicity, but he's really uncomfortable and breathless. He may or may not want intervention for the effusions to relieve his breathlessness, but if we were looking purely from a comfort point of view, we could think about introducing a subcutaneous infusion with a low dose of hydromorphone and midazolam here, just to help him relax and help take the distress out of that breathing. We might want to introduce a small dose of haloperidol, maybe 0.5 or 1 milligram over 24 hours for the hallucinations, just to see if we could help with those. So we'd want to talk to family, obviously. Hopefully as the GP you might know who the most appropriate person to talk to was, and hopefully we've had those conversations much earlier in the illness so that we've defined who those important people are, who he would want to speak for him on his behalf at this point in time, and what his wishes were. So we would go through those conversations we talked about earlier, and we've talked about the medications. Obviously, if he were to die, this would be a coroner's referral, and we'd need to make sure that the family or the important people were aware that that was going to be necessary and that a death certificate couldn't be issued until the coroner was informed. So here we are. So he had a continuous infusion with 2 milligrams of hydromorphone, a milligram of haloperidol, and we may or may not want to put a low dose of midazolam in there for restlessness. And also the combination of both opioids and midazolam has been shown to be more effective than either alone for breathlessness. So we might just want that, even 5 milligrams of midazolam over 24 hours in there. And then PRN medications for all of those common symptoms that we've talked about. He may benefit from a bit of furosemide, which we could give subcutaneously at 40 milligrams as a once-off. So involvement of the nursing team, thinking about the potential for a catheter so that he doesn't have to worry about that, and support from the palliative care team if that's needed. We'll just talk about the last case here. Margaret, 86-year-old lady in a residential aged care facility. She's now bedbound, reduced oral intake, has a 5-day history of increased confusion and hitting out at staff, isn't able to communicate verbally, and has rubbed off all her hair from the left front area of her scalp. She's known to have advanced dementia and a previous history of alcohol use and liver cirrhosis and gastroesophageal reflux disease. So she's on some buprenorphine. She's been on risperidone. She's been on vitamin D, thiamine, pantoprazole, paracetamol, caloxylin, senna, and calcium supplements, the majority of which could be discontinued as she enters the final phase of life. So there we can continue with her buprenorphine patch if that's been achieving pain control. We'd have PRN opioids prescribed. We may or may not want to replace her risperidone, perhaps with a small dose of subcutaneous haloperidol. We could give that twice a day subcut if we've got somebody to go in and administer, or we could start a small infusion. And if she's very restless, again, we might want to think about very low doses of midazolam alongside. This lady's got a very distended abdomen. She's got laboured breathing again. Family here concerned about the fact that she's not eating and drinking, and the fact that they'd really like her put out of her misery, feel as though they'd for her own sake, they'd rather that time was shorter. So here, a lot of this is about conversation with the family and reassuring them that actually she's unlikely to have a thirst or hunger sensation as she becomes close to the end of life because of the buildup of ketones when she's not been eating, and that actually currently in Western Australia, we can't assist her to die at this stage, but we can certainly look at alleviating her distress. We note that this daughter is not the enduring guardian here, so we might want to have a chat to whoever holds that or her substitute decision maker that she's elected if she's got one, just to check that whatever we're planning to do with medication is in keeping with what Margaret would want. So there we go. And she'd have all those PRNs. Now, if we thought she might be in pain, we can look for signs of distress. We can look for grimacing, sweating, tachycardia, and so on that might suggest pain. We might want to give her a low dose of morphine in the background there as well, if there was any indication that she was in pain, particularly if she was in pain despite the buprenorphine. So here we are. In terms of resources, there are on the presentation that you will have received a number of websites that you can access that will help to guide you in your practice. You can see them listed here. I'm not going to go through them all individually. There's an app there that you can download that you may find very helpful, that just helps you guide you in terms of treatment of pain. And again, some more websites you might find helpful, and particularly there some resources that will help you in terms of caring for Aboriginal people as well. There we go. Thank you for your time.